At the outset, I would like to thank the team AIMS, PGI, and HCPGI, led by the giants of India, working in gastroenterology for past 3 decades, for inviting me here on to talk about immunotherapies in the real world. So what actually is immunotherapy? What is IMBRAVE 150? How to choose your patient? What are the few cases what we discuss over here? How can we downstage the patient to transplant? Transplant, it is a curative therapy. How many cycles of immunotherapy to be given? How to assess the response? What are the predictors? Real world data, and what are the adverse events? So what actually are the immunotherapy? This is for the fellows. The genetic and cellular alterations that characterize the cancer cells can be recognized by the immune system as foreign, resulting in T cells being able to kill the cancer cells. But we want to kill the cancer cells while the cancer cells want to survive. So they overcome this by acting potentially and inhibiting the tumor anti-tumor response. Tumors can overcome this, but disrupting the balance governing the steps of cancer immunity cycle to specific checkpoints called as immune checkpoints. So what we want to do is anti-cancer immune response can be potentially enhanced by activating the stimulatory checkpoints or by blocking the inhibitory checkpoints. These are the ones which are in use. Nivolumab, unfortunately failed. PD-1 inhibitor, the p-value is 0.07. Atezolizumab in combination, this is a PD-L1 inhibitor in combination with bevacizumab, that is an anti-VEGF inhibitor, has shown to be very effective and is available in India. Durvalumab, PD-L1 inhibitor, again a little costly drug, but in combination with Romilumab, that is Himalayan trial, said that it is effective but yet to be available in India. What are the terminologies I will be discussing over here is overall survival. It is the duration of survival from the administration of the first dose to the death. Progression-free survival is the time required for the radiological progression of the disease or death from the initiation of the drug. How to assess the response is based on RECIST and mRECIST, that is response evaluation criteria in solid tumors, and the modified RECIST criteria. In RECIST, we have the size has to decrease, whereas in mRECIST, the enhancement has to decrease. There are 2 things which are always written in these drugs, the drug trials, that is objective response rate, ORR, that is the combination of complete response plus partial response. BCR is nothing but combination of complete response, partial response plus stable disease. So this was a breakthrough. In 2020, we had this atezolizumab plus bevacizumab showing a very effective drug for HCC. I know it's quite not cost. I think it's cost effective, but I am sure it's not very. Will stare at me. Anyway, we have there is good overall survival. The updated survival analysis showed that 19 months overall survival. There was good progression-free survival with this drug. There was better objective response rate, better disease control rate, which was not seen with sorafenib. But there are few caveats. Following this approval, there is significant increase in the use of atezolizumab in US from 7 to almost 70%. There's a reduction in the use of sora and lenvatinib from 40% to less than 10%. But is it feasible? IMBRAVE, all these trials are done in untreated HCC, child pug A, PCOG score less than 2, good performance status. But that's not same here in India. We had this beautiful study from PGI, almost 785 patients, of whom 677 were cirrhosis, and only child A cirrhosis accounted for less than 40%. That means most of our patients present in advanced stage, intermediate to advanced stage, BCLC B or C. Similar experience with us from South India, that most of our patients are child B on those who received these tyrosine kinase inhibitors. Not that we are unique, this is also same from US as well. This is the data of 1620 patients, where they said the advanced, they present with child B and C accounted for more number than child A. Following this was a study published in Hepatology that child B can also tolerate atezolizumab. They have similar safety data, but probably the concern is overall survival, which was lesser. There was a beautiful letter from PGI. Should we extend the boundaries of this using atezolizumab to child B as well? So how to choose your patient? This was a 68-year-old male, good performance status, BMF 28.9, NASH cirrhosis, high alpha-fetoprotein, child 7B. Not very keen for any procedures, not very keen for transplant due to some personal reasons. So we gave him 6 cycles of immunotherapy, following which there was complete disappearance of the tumor. And he continued the cycles for now, almost 9 cycles have been continued. The second thing, when and when not to choose a therapy. 70-year-old male, NASH cirrhosis again, a good performance status, alpha-fetoprotein 171, diagnosed and started on sorafenib elsewhere. His bilirubin of 3.8, albumine 3.5 at the time of presentation to AIG. Child 8B, no potential donors already listed for transplant. What should we do? Should we continue sorafenib, stop sorafenib to immunotherapy, to a TARE, SBRT or TACE? So this patient actually, when the bilirubin is high, we don't give any systemic therapies. We tend to avoid systemic therapies because we have more liver injuries. So we stopped sorafenib, waited for a few weeks. The bilirubin reduced. We took him for a TARE. Post TARE, there was the reduction in the enhancement, and we also gave him 3 cycles of atezolizumab after 3 weeks of TARE. And after 6 cycles, the tumor completely disappeared. But later on, when he continued the therapy, he developed ascites, the liver disease progressed, he developed SBP, and still awaiting transplant. He was 70-year-old, and now he's 71.5 years. Doing okay, but the recent last week MRI showed they have developed again the new lesions. We stopped the treatment because of ascites and SBP. So what are the questions in this? Is age a barrier for immunotherapy? Why TARE for this patient with why TARE plus atezolizumab? How long should we administer the therapy? Can we switch to tyrosine kinase inhibitors post progression? How to assess the therapy, and is CTBB a good choice? Age is not a barrier. This was a beautiful study published in Liver International. Less than 65 and more than 65 years, both of them have similar overall survival and progression-free survival. Why did you combine TARE plus atezolizumab? The rationale behind this is the heterogeneous immune microenvironment inside the liver, which the patient may not respond to immune checkpoint inhibitors. When we do a TARE, there is increased antigen presentation, which can be again targeted by atezolizumab. There is a large RCT underway on combination of TARE plus atezolizumab versus TARE. How many cycles? These are the data and the literature. The number of cycles is actually dependent for us basically on the logistics and the finances of the individual, but it is recommended to continue till the disease progresses. The literature says average 3 to 6 cycles have been used. So median we have used around 6 cycles, 3 to 6 cycles average, and probably they either shift to the tyrosine kinase inhibitors or have a progression. How to assess? It is recommended to do a CT or MRI after 6 to 12 weeks. That is after 3 weeks, 3 doses. Get a CT scan done to look for a response, whether it is progressing or stable or has responded. If available and also affordable, get a PET scan. We usually tend to do PET scan after 6 cycles to assess for metastasis. Is there a role of alpha-1 protein for assessment? Yes, AFP less than 400 baseline can predict better overall survival and progression-free survival. And if there is a decline in AFP by 20 to 50% at 6 weeks, it can also predict better progression-free survival and overall survival. These are the predictors which are in the literature. Most importantly, it is alpha-fetoprotein, neutrophil lymphocyte ratio, and several of them. And if you give a local regional therapy prior to immunotherapy, there is improved overall objective response rate in these patients. We wanted to assess our own data to assess the predictors of response to atezolizumab in the real world. We included around 67 patients. Professor Saraswat and Dr. Karan were kind enough to share the data. We had around 8 patients from Mahatma Gandhi Hospital, Jaipur. These are the baseline characteristics. Child per A was 35%, B were 53%, C 10.4%. We had the oncologist on our board. Several of the patients had undergone one or the other therapies prior to receiving this atezolizumab. The overall survival and progression-free survival was completely dependent on the child PUC score. In child A, it was 21 months, child B, 9 months, child C, hardly 4 months. So child C, don't give any immunotherapies, best supportive care. The tumor may not be aggressive, but the physician need not be aggressive. So it is definitely dependent on child PUC score, overall survival and progression-free survival. Several of the studies have said that it is dependent on child score. The adverse events, what we noted, whether it was higher in patients who received child B as well. So there is a similar amount of adverse events in child A and child B, that is 12 and 14%, but child C almost 85% developed adverse events. Varicose bleed, which is the major concern for all of us, being gastroenterologist and hepatologist. The first page, there are 2 patients in child A, both of them had bleeding. One patient had a history of previous varicose bleed, underwent eradication, again received therapy, and again bled after around 3 weeks of first therapy. We changed into atezolizumab only, but he couldn't survive. After around 3-4 months, we lost him. The second patient, after 4 cycles of immunotherapy, he bled. He had a small varices prior to therapy. He was on beta blockers. He had a major portal vein thrombosis, but we changed him to atezolizumab, and he's been on atezolizumab for the past 4 cycles. So should we do endoscopy for all? Yes, endoscopy is a must, but prophylactic banding just to give a drug I'm not quite keen of doing prophylactic binding, especially for patients with portal vein thrombosis. This was a study published in Clinical Gastroenterology and Hepatology. 194 patients, 1 or 2 patients had a EGD for 3 weeks prior to therapy, and there were 8 patients who had bled after 1.5 months. The only predictor of the bleed was major portal vein thrombosis. Prophylactic treatment did not reduce the incidence of bleed. So treating varices prior to with eradication is difficult in our setting, especially for PVT patients. Can we switch to tyrosine kinase inhibitors if the patient progresses? Yes. If the atezolizumab has been used for second line therapy, there is better overall survival compared to not receiving atezolizumab. But our patient was in child C, so we didn't starting on tyrosine kinase inhibitors. We know that we have been using sorafenib and elnatinib for a long time. The patient is intolerant. Can them be changed to atezolizumab? Yes, this was a study published in Hepatology Research. So 50 patients who were intolerant were given second line and third line drug as atezolizumab. They had better overall survival post progression on the first line. They had good objective response rate and disease control rate as well. The study till now we had compared atezolizumab with sorafenib, which was the IM Brave trial. But this is the study which is published by Chen et al. If I'm not wrong. It is to compare propensity match patients with atezolizumab versus lenvatinib. There is better overall survival, better progression-free survival with atezolizumab than lenvatinib. The major disadvantage of atezolizumab is the risk of bleeding events. Hypertension, anorexia, fatigue were all commoner with lenvatinib than atezolizumab, but the bleeding events were quite common with bevacizumab. In Taiwan, they used lower dose of bevacizumab to prevent the adverse events. They use around 5 to 7.5 mg per kg body weight, whereas the recommended one is 15 mg per kg body weight. In our hospital, we use around 10 mg per kg body weight. I think in Jaipur, they have fixed the dose of around 500 mg these days to prevent the adverse events due to bevacizumab. So there are several other studies which say that although the reported incidence is there around 20%, but the cumulative incidence of variceal bleed in carefully selected patients is probably less than 10%. In summary, immunotherapies are an excellent treatment option. I would suggest to read Professor Kudo's ABC, atezolizumab followed by curative conversion treatment, published in liver cancer, how to treat intermediate and advanced cancers. It's not just, I know we are financially limited here in India, but there are definitive therapies. The patient can have prolonged life. The patient here, in our patient, we had 1.5 years of survival post diagnosis of HCC is quite good, according to me. The one which is available in India is atezolizumab. Choosing the right patient is the key to success. Combination therapies, that is locoregional therapies with immunotherapy is better. Variceal bleed is less probably than feared. STRIDE, which is yet to come in India, it's a Himalayan trial published in NEGM Evidence. The single dose of tremelimumab followed by durvalumab regular intervals at 4 weeks had shown to be better than single dose of regular intervals of durvalumab. But the only drawback for us is the cost. I would like to end my talk. Thank you.